Bismillahirrahmanirrahim. Assalamu alaikum and a very warm welcome to our audience for to a new session of ophthalmology teachings. Dear audience, today we are going to discuss about a very important topic, very important disease which affects central vision. That is age-related macular degeneration. There are multiple factors, genetic, environmental, aging, all these contributing and playing a role in the involvement of the central macula, which ultimately leads to decreased vision. Today, we have invited our special visiting guest, Professor Joaquin Alfredo Buffoli from Argentina. We are thankful to him that he has accepted our invitation and given time to update and educate our audience. Professor Alfredo, Joaquin Alfredo Buffoli is a professor and chair of ophthalmology, faculty of medical sciences, National University of Rosario, Argentina. He is a medical director, diagnostics and eye surgery center specialist. He is also director of macular department of ophthalmology services, Centennial Hospital, Rosario, Argentina. Vice director of medical specialist of ophthalmology, faculty of medical sciences, National University of Rosario. Apart from this, he is also vice president of Argentinian Society of Vitreoretina. A number of publications to his credit. He is co-authored and authored many books. He's a teacher, educator, and playing an important role in that area, and also in retina management. And for years, he has been training the physicians. He's also a member of the board of directors of Pan American Association of Ophthalmology since between 2011 and 19, and a founding partner of Argentinian Society of Vitreoretina. So we can take a lot of time more to explain and introduce him. So cutting short, that he's a scholar, and we are very fortunate to have him today with us. So without further delay, I will request Prof to please present his talk.
Okay, thank you, Dr. Alim, for your kindly presentation and invitation. Today, the topic is AMD, dry AMD, and its diagnosis. AMD is a disease described in its latest stages by dysfunction and death of photoreceptors secondary to both choroidal retinal atrophy and or neovascularization. It's the main cause of legal blindness in people over 60 years of age in developed countries. And dry AMD with geographic atrophy is an advanced bilateral AMD described by progressive and irreversible loss of photoreceptors, RPE, and choriocapillaris. But when it covers the fovea, the VA is low and with a low functional vision, quality of life, and loss of independence. How to assess dry AMD with GA? Okay, we have a lot of tests, morphological tests on the right, on the left, and functional tests on the right. We have very little time, and today we will talk about morphological tests as autofluorescence, color fundus photography, spectral domain OCT, near infrared reflectance, fluorescein angiography, OCTA, and bioelectrical tests. Between functional tests, we can find the best corrected visual acuity, Amsterdam grid, reading speed. We use Minnesota test, microperimetry, contrast sensitivity, BCVA in low light. We use Kodak red and neutral density filter, dark adaptation test, and color vision test. Maybe the oldest morphological test is the color fundus photography. You can see the pictures increased visibility of choroidal vessels, reduced retinal thickness if you use stereotype mode. Sometimes you can find large soft drusen, calcified drusen, pigmentary changes surrounding the area, and peripapillary atrophy. It's very good if you can do a color fundus, but if you can do an autofluorescence in these patients, it's better. Pathological hypoautofluorescence is due to the complete loss of metabolic activity of RPE cells. And pathological hyperautofluorescence is due to the metabolic disorder of RPE cells which accumulate of lipofuscin. There are two important studies in the past when the authors described perilesional autofluorescence patterns as non-focal, band, patch, and diffuse. Between diffuse pattern, you can find reticular, branching, fine granular, trickling, and fine granular with peripheral stippling. This is important because some of them, like fine granular or trickling, are diffuse pattern that can have a faster evolution for these patients. Here you can see an area of GA, and around it, hyperautofluorescence in granular fine diffuse pattern. Autofluorescence areas outside GA reveals morphological alterations in the RPE and outer retinal layers and can predict atrophy. In this case, you can see the evolution of this patient. Other test is fluorescein angiography, and it's important in the early times, but you can see the choroidal vessels, but it's better in the later times where you see the window effect by loss completely of RPE cells. Other test is near-infrared reflectance. This test uses near-infrared wavelengths. These wavelengths absorbed less by medioposities, neurosensory layers, and macular luteal pigments than autofluorescence wavelengths. Areas of GA appear brighter than areas without atrophy, useful for evaluating the degree of foveal involvement in GA. For example, here you can have a patient with autofluorescent test, but you really don't know if the fovea is free or not. But if you do near-infrared reflectance, you can see in a small area free in the fovea, and this can explain why this patient can see or can have a very good visual acuity. The size of the lesions are very important too. If the patient has lesions small, less 1.3 millimeters, the progression rate is 0.8 millimeters per year. If the lesion is more than 8.3 millimeters, the progression rate is 3 millimeters per year. If you have a patient with multifocal lesions, extrafoveal lesions, and diffuse patterns in the autofluorescence, be careful because these patients can progress faster. For example, extrafoveal lesions, multifocal lesions with diffuse pattern in trickling, and in few months, the evolution of these patients. Other case, similar, extrafoveal, multifocal, and diffuse pattern in the autofluorescence in trickling, and in few months, the quick evolution. Obviously, OCT maybe is the best test because you can see very well the external layers of retina and choroides. Many authors described phenotypic retinal features associated with increased risk for GA on OCT. For example, intraretinal hyperreflective foci. Generally, these changes have similar reflectance than RPE cells, and generally they are on the RPE layer. Here are other example of hyperreflective foci. Other feature is the size and volume of drusen. If you have a very small drusen, isn't a problem, but if the drusen are greater, these are features associated with increased risk. Other feature is calcified drusen. It's like hyperreflective foci, but inside the drusen. Other feature is when you find arrowheads on the RPE cells or on the RPE layer. You can see very well with spectral domain OCT, but you can see very well with near infrared reflectance too. Other example of these changes. Other feature is the thickness of the choroid, and in the picture you can see a normal thickness, but if you have a patient with a very thin choroid like this, is other feature associated with increased risk for GA. Some authors describe a classification of atrophy meetings in RPE and outer retinal atrophy, RORA, in incomplete RORA or complete RORA. At the beginning, the first changes are called nascent GA. What is nascent GA? Let me show you an example. Here in the baseline, we have a patient with soft drusen, RPE detachments, and in few months, in 6 months, you can see the collapse of the drusen. In this moment, you can see two changes. They are the first changes. One of them is subsidence of the outer plexiform layer and inner nuclear layer. And the second is hyperreflective wedge-shaped lesion in Henle's nerve 5 layer. Here we can see better. You can see the subsidence of internal nuclear layer and outer plexiform layer, and the hyperreflective wedge-shaped band. These are two changes at the beginning in the evolution of these patients. Then the patients can go on to incomplete RORA. What is incomplete RORA? Okay, must have all three of the following. First of all, they must have the wedge and the subsidence as we saw before. Some irregularity in the complex Bruch and RPE layer. Some hypertransmission in choroides must be present, but often discontinuous. And then with evolution, in these patients, they can go on to complete RORA. This is the same, but greater than 250 microns in each lesion. Why is important these concepts? Because we know 90% of new incomplete RORA lesions progresses to complete RORA by 24 months. If the lesions are near of the fovea, it can meaning that pass the normal visual acuity to legal blindness in these patients. Here, an example, a patient with very good luck. You can see the changes at the beginning outside the fovea and how the changes are transforming in complete RORA, but outside the fovea, and this patient has a very good vision. Other example with very good luck, these are huge areas of geographic atrophy in the autofluorescence, and in the OCT, you can see the external structures free of GA as ellipsoid zone and external limiting membrane, and this spurt can explain the very good corrected visual acuity, best corrected visual acuity in this patient. To sum up, the correct form to assess this kind of patient is in the multimodal way, with color fundus photography, with autofluorescence, with fluorescing angiography in yearly and late times, with OCTA in unfast mode. In the last time, it grew a lot, and obviously B-scan OCT and near infrared reflectance. I think this is the last. Yes. Thank you very much for your attention.
Well, thank you, Prof. It was a very informative presentation, and especially you highlighted the concept of complete and incomplete RORA. I believe it will be very beneficial for our audience. Just a few questions, Prof, I want to ask you. As you are an expert in this field, Prof, what do you consider the most important morphological test for the evaluation of AMD with GA?
A very good question, Doctor. I think the correct way is a multimodal way. But if you haven't all the tests, maybe with spectral domain OCT and autofluorescence, it's enough to have a very good diagnosis and prognosis for these patients.
Right, Prof. Prof, do you also use diagnostic tests to determine the progression of the disease?
Yes, it's very important because you can see with both, with spectrum domain OCT and with autofluorescence, some changes. They are talking about the evolution of the disease. For example, in the OCT, you can see, as we saw, nascent atrophy geographic and incomplete and complete RORA. And if you have autofluorescence, you can see different patterns like diffuse patterns, and maybe with some of them, the patients can progress faster.
Right, Prof. How now, after the evolution of then this introduction of OCTA, how beneficial is Prof OCTA in this disease management and progression, Prof? OCTA.
OCTA.
Yeah, angio.
Yes, OCTA is very important in the last years, especially in the unfast mode. With unfast mode, you can see the the tissue structures beside the plexus, the vascular plexus. You can see the tissue, and in this kind of patients, you can see the extension of the lesion in geographic atrophy very well.
All right. Prof, you are a principal investigator, although I know this is not approved in South America, but you were the principal investigator and you did a lot of work on anti-complement therapies, Prof. So what is your experience? You did for almost 3 years about these two molecules. So what is your opinion about these therapies in future?
Our experience was similar to the final results of the studies. The patients were contentos or happy with the treatment because they know this treatment isn't for improve the visual acuity, isn't to improve its disease. It's just to allow the evolution of the growth of the GA areas.
Right, Prof. Right, Prof. Prof, you talked about autofluorescence tests. You go for the blue light or green light, Prof?
We use frequently blue light because we have Heidelberg machines. With blue light, you have a very good definition and very good contrast. But in some cases, for example, when the geographic atrophy is near of the normal autofluorescence in the center of the macula, it's difficult to know if the atrophy is taking the center or not. In these cases, you can use green light. The machine that use green light is Optos, and you can see better in this kind of changes.
Right, Prof. Right. Prof, well, it was a very beneficial talk, and I believe that it will be of great interest, especially you introduce some new concepts, and you are an authority, of course, on this field. And it will be very beneficial and for our audience, Middle East and internationally. You have given us time. We are grateful to you. And we really got a lot of benefit from your knowledge, experience. And we are looking forward to further collaborations in future also, Prof. So once again, thank you. And also thank you, Marina, for assisting us.
Thank you, doctor. Thank you, and congratulations for your activity.
Thank you, Prof.